I'm Dr. David Johnson, professor of medicine and chief of gastroenterology at Eastern Virginia Medical School and Old Dominion University in Norfolk, Virginia. Welcome back to another GI Common Concerns, and I wanted to touch base with you on diverticulosis and diverticulitis. It's an incredibly common finding that we see diverticulosis. It's estimated that over 70% of people that have colonoscopies 80 or more years of age will have diverticulosis. So we see it a lot. And we tell the patients that, and the questions that I get frequently are, well, what do I need to do? Or if somebody comes back with diverticulitis, and approximately 4% of those people with diverticulosis will have an episode of diverticulitis in their lifetime. Roughly 15% of those will have complicated disease. So patients always want to know, what do I need to do if I can prevent it potentially or prevent a recurrence? So let's talk about the evidence and really what we should be discussing with our patients. I bet it's changed since the last time you thought about this, perhaps, and the conversations really need to be evidence-based and current. So let's give you an update on where we are presently. One that is cardinal has been the emphasis of diet. We were all taught whenever you were coming through and learning about diverticulosis and diverticulitis that axiomatically you need to avoid corn, nuts, and seeds. Well, that was really challenged in a prospective cohort study back in 2009 done in men that suggested that none of that was evidence-based, and there was really no association with those dietary restrictions as it relates to those people, the men developing diverticular complications, diverticulitis. Now, why is that important? Well, it was done in men. The study was never replicated, but the lifetime risk is higher in women. It's about 5% as opposed to men, 3.1%. So welcome the most recent study that was published in the Annals of Internal Medicine done from the folks at University of North Carolina, where they looked at, again, a validated prospective evaluation, serial examinations in patients that were not specifically enrolled to follow up diverticulitis. It was particularly a breast cancer sister type of surveillance. And these patients were using validated instruments to assess diet, and then looked at the incidence of diverticulitis as it relates to the iterations of over time. So again, not subject to recall bias. In fact, that they looked at nearly 415,000 patient years and 1,500 plus patients that had diverticulitis, and there was no effect as it relates to diet with those particular elements. So fresh fruits, even with seeds, obviously nuts and seeds and corn, none of that made an influential difference as it relates to either the association with diverticulosis as a primary diagnosis or the development of diverticulitis or the development of complicated diverticulitis resulting in abscess, surgery, or fistulization. So none of those seem to be relevant, and we really can start to look at what we tell our patients. You don't necessarily have to avoid those things, but a good diet does seem to be resident. So a low inflammatory diet, Mediterranean type diet, and there are a number of diets that were looked at in this most recent study in women. Basically, I tell my patients a Mediterranean type diet, low inflammation, those things are really very easy to follow and make good sense. The recurrence rate for diverticulitis, as we talk about the recurrence over time, is notable because approximately 20% will have an episode of recurrence within 10 years. Approximately 8% will have a recurrence within the first year after complete recovery. So we do need to make the patients forewarned that this may be something that incurs and that the risk increases if they have subsequent episodes. So after a second episode, the risk is increased to 18% at 1 year and 50% at 10 years. And after a third episode, it's 40% at 3 years. So again, anything we can do prospectively and proactively, the patients are better potentially enabled to prevent a recurrent episode. Now, this is something that's relatively common sense, but some of the associated risk factors for diverticulitis, the patients can easily follow. One is smoking reduction or smoking abstinence. Alcoholism, but not alcohol in and of itself, is something that is associated with a higher risk. Comorbidities that certainly that light up here are patients that have needs for chronic NSAID use. So we generally would recommend, as a guidance from the guidelines, is to recommend avoidance of regular use of NSAIDs, cardiac aspirin when justified for cardiac indications is something that certainly should be continued. But weight reduction, particularly the truncal obesity, seems to be a resonant risk factor for diverticulitis. So these are things that the patient can work on, and certainly going forward. And physical activity, in particular vigorous physical activity, is also has a negative relationship, an inverse relationship, beneficial relationship for diverticulitis. So healthy diet, avoidance of regular NSAIDs, really kind of good common sense type things make sense going forward. It's important for the patients also to recognize that if they have a recurrent episode, the rush to antibiotics has really changed, and the evidence around this and guidelines support this now, that it's not necessarily for uncomplicated diverticulitis that antibiotics don't seem to do better than antibiotics, so no antibiotics. So the restrictions are for patients that have, they're frail, multiple comorbidities, that they have immunocompromised state, or lab evidence of some fluid collections or high CRP greater than 140 milligrams per liter, or a high white count over 15,000. These are things where antibiotics obviously are indicated right away, but generally we tell patients clear liquid diet, no antibiotics. Keep us posted if there's any other alarm features, particular fevers or worsening pain. Obviously then they need to have this, and an extent of diverticulitis involvement on a CT scan would also be an indication for antibiotics. So again, not rushing to a CT scan in all these patients as we start to be more cognizant of some of the radiogenic risk. And we've talked about this previously, and I'll refer you back to that discussion as we talk about radiogenic risk for CT scans and abdominal CT scans. Vitamin D status is also something that's really important. And I touched on this in my most recent viewpoints, and I'll give you a link back to that if you haven't seen that, but recognize that vitamin D levels that are low are associated with a higher risk for diverticulitis, complications of diverticulitis, again, abscess, early surgery, fistula formation, abscess. So again, vitamin D, I check that routinely on patients, and I'll generally push the vitamin D supplements. I see a very low risk for any supplemental vitamin D, and I would certainly put that in the realm of diverticular disease, potentially in a prophylactic way, or certainly in patients that have had diverticulitis. It's important also to tell the patients that there is a high genetic predisposition. This is something I think we really missed discussing with our patients. But there are over 30 loci that have been associated with diverticulosis, 4 of which seem to be particularly associated with diverticulitis. So when you start to talk about siblings and patients that have had family history of diverticulitis, in particular monozygotic is higher than dizygotic, but nonetheless, this is a significant risk factor, accounting for about 50% of the recurrence risks for recurrence risk for diverticulitis. So in those patients, we really need to be proactive in anything we potentially can do. And again, recognize that's a historical question to ask about, but be maybe identifying patients at greater risk for the disease development or recurrence. And the final thing is just to talk about is the use of the imaging that we really need to back away from. CT scans, I think, are really overutilized, and we potentially need to take a step back on when we use these. And certainly there are proactive things we can do. One final comment is that I always tell my patients you have a likelihood, about a 45% chance of having some intermittent lingering symptoms. So it may be some intermittent cramping, potentially those things. And it's attributable mostly to visceral hypersensitivity. There may be a biomic explanation for that, but motility-related muscular changes in relation to diverticular disease. But assuring the patients that that's not something they need to go to an alarm feature of, got to call the doc and let them know about that, or the care provider, but let them know that that is something that potentially may require some antispasmodics, maybe some low-dose antidepressants as it relates to visceral change modulation. But again, different than the acute and the persistent worsening pain that is typified for diverticulitis. So hopefully some of these conversations give you a better insight and give you more practicality and evidence as you start to talk with your patients. I think they'll be a lot more meaningful and certainly more evidence-based. We can do a better job, and hopefully these give you some good guidance in doing so. I'm Dr. David Johnson. I look forward to chatting with you again soon. Thanks again for listening.